Good afternoon, dear students. The topic of our lecture is differential diagnostic and differential treatment of arrhythmias and bloks. Normal sinus rhythm is a right sinus rhythm with rate from 60 to 90 or maximum to 100 beats per minute. On the ECG, sinus rhythm is characterized by a PV upright in the second, third, and AVF and inverted in AVF lead, followed by torus complex. Normal range of PQ interval is 0.12 to 0.20 seconds. Definition: arrhythmia is abnormal frequency, regularity, or consistency of excitation and contractions of heart. Block is a deceleration or discontinuation of impulse movement on conducting heart system. Etiology: cardiac causes of arrhythmias are myocardial infarction, coronary artery disease, left ventricular aneurysm, mitral valve disease, cardiomyopathy, pericarditis, myocarditis, aberrant conduction pathways. And non-cardiac causes are caffeine, smoking, alcohol, pneumonia, drugs, metabolic imbalance, also thyroid disease and pheochromocytoma. Pathogenesis. Two general factors have the undoubted role in the base of arrhythmias: change of functional parameters of natural's normal automatism centers or appearing in myocardium new pathologic centers of impulses. Re-entry phenomenon: return enter, single or numerous return of excitements with at the same zone of myocardium. Heart blockades develop as a consequence of structural, permanent or functional temporary disturbances in heart's conduction system that prevent normal spreading of excitements with. Classification of the arrhythmias. Arrhythmias can be slow, such as sinus bradycardia or heart block, and fast, sinus tachycardia, atrial tachycardia, supraventricular tachycardia, junctional tachycardia, and ventricular tachycardia. There are several classifications of arrhythmias and blocks by location. Arrhythmias can be ventricular and supraventricular. The last one can be sinus, atrial, or atrioventricular. By clinical cause, arrhythmias can be acute, chronic, or paroxysmal repeating. By influence on hemodynamic, arrhythmias can be safe, without dangerous, potential dangerous, dangerous, and fatal. By heart rate, arrhythmias can be tachy, more than 100 beats per minute, or bradyarrhythmias, less than 60 beats per minute. Diagnostic of arrhythmias and blocks consists of clinical features, ECG signs, Holter methods of ECG registration, electrophysiological research of heart, reflection, vagal and drug tests, and other laboratory and instrumental tests. Treatment. Treatment of arrhythmias and blocks included elimination of causes and special methods. Special treating methods are antiarrhythmic drugs, electrical methods of treatment, surgical treatment, reflection and mechanical influence, and psychotherapy. Classification of antiarrhythmic drugs. There are four main classes of antiarrhythmic drugs. Class 1: fast sodium channel blockers. There are three subgroups in this class: first A, first B, and first C. First A, it's quinidine, it's diazepamide, and procainamide. Depressed phase 0 and prolonging repolarization. Class 1b, lidocaine, phentoin. Depressed phase 0 selectively in abnormal or ischemic tissue and shorting repolarization. Class 1c, for example, flecainide, propafenone. Markedly depressed phase 0, minimal effect on repolarization. Class 2. Beta blockers such as propranolol, ethmolol, timolol, metoprolol, and atenolol. Propranolol decreases slope of phase 4. Ethmolol decreases slope of phase 4 also. Timolol decreases slope of phase 4. Metoprolol and atenolol also decreases slope of phase 4. Class 3 potassium channel blockers amiodarone, sotalol, ibutylide, dofetilide. Amiodarone prolongs phase 3, also acts on phase 1st, 2nd, and 4th. Sotalol prolongs phase 3 and decreases slope of phase 4. Ibutylide prolongs phase 3 and dofetilide also prolongs phase 3. And class 4 slow calcium channel blockers, verapamil and diltiazem. Two of them prolongs phase 4. Phase 2. Variable mechanisms, so-called fifth class of antiarrhythmic drugs. It's adenosine, digoxin, and magnesium sulfate. The other methods of treatment is cardiac electrical therapies, such as ablation, defibrillation, and cardioversion. Ablation is a medical procedure that involves using a radioactive catheter to induce tissue destruction to eliminate source of recurrent arrhythmias. Multiple catheters, mapping ablation and defibrillation are inserted through the groin bilaterally up to the right atrium. Defibrillation consists of delivering a therapeutic dose of electrical energy to the heart with a device called a defibrillator. Defibrillator is non-synchronized, untimed delivery of energy during any phase of the cardiac cycle. This depolarizes a critical mass of the heart muscle, terminates the dysrhythmia, and allows normal sinus rhythm to be re-established by the body's natural pacemaker in the sinoatrial node of the heart. Indications and contraindications of defibrillation. Indications are pulseless ventricular tachycardia and ventricular fibrillation, and contraindications are awake, responsive patients, any arrhythmias in a patient with a pulse. Cardioversion. Synchronized electrical cardioversion uses a therapeutic dose of electrical current to the heart at a specific moment in the cardiac cycle. Timing the shock to the air wave prevents the delivery of the shock during the vulnerable period of the cardiac cycle, which could induce ventricular fibrillation. Indications of cardioversion. It's atrial fibrillation, atrial flutter, ventricular tachycardia, and paroxysmal supraventricular tachycardia. Contraindications of cardioversions. Dysarrhythmias due to unchanged automaticity, such as digitalis toxicity and catecholamine-induced arrhythmia. Cardioversion is not only ineffective but is also associated with a higher incidence of post-shock, ventricular tachycardia, and or ventricular fibrillation. Types of defibrillators: manual external defibrillator, manual internal defibrillator, automated external defibrillator, and implantable cardioverter defibrillator. On the picture you can see manual external defibrillator example, manual internal defibrillator. Sinus tachycardia. Clinical features of sinus tachycardia. Patients complains on palpitations. On the ECG, sinus rhythm with frequency 100 per minute and more is registered. Treatment. You have to identify and treat the cause. Sometimes you can use beta blockers or calcium antagonists. If the cause of a sinus arrhythmia is systolic heart failure, you can use digoxin according to the indication. Sinus bradycardia. Clinical features. It can be asymptomatic or cause hemodynamical changes, systemic, such as heart failure, low blood pressure, and regional, such as syncope or angina. On the ECG, sinus rhythm beat frequency less than 60 per minute is registered. Treatment of acute causes. If sinus bradycardia is asymptomatic and rate is more than 40 beats per minute, no treatment is required. If rate is less than 40 beats per minute or patient is symptomatic, give atropine. If no response, insert a temporary cardiac pacing. In chronic causes, if the patient is symptomatic, you can use permanent pacing. Premature beats, so-called extrasystoles. Premature beats is extra premature excitation and contraction of the heart. Clinical features. It may be asymptomatic or cause palpitations. Sometimes it can cause hemodynamic disturbances. On the ECG, atrial premature beats looks like normal complex QRS, and ventricular premature beat has a wide QRS complex without a presiding P wave. Treatment. Extrasystoles don't require treatment in most cases. Beta blockers can be used in symptomatic arrhythmias. Types of extrasystoles. You can see on this picture atrial, it's A, nodal, picture B, ventricular, picture C, and polytopic, picture D, extrasystoles. It's premature supraventricular extrasystole, it's ventricular extrasystoles, the picture with ventricular extrasystoles. Atrial fibrillation is a rapid irregular atrial rhythm. Clinical features. Atrial fibrillation is often asymptomatic, but many patients have palpitations, chest discomfort, or symptoms of heart failure. On the ECG, findings include absence of P waves, F waves between QRS complexes, and irregular RR intervals. Treatment. Electrical and medicamental cardioversion are used for atrial fibrillation convention to normal sinus rhythm. For medicamental cardioversion, propafenone, amiodarone, and procainamide are used. For rate control, beta blockers, calcium antagonists, and digoxin are used. For prophylaxis of thromboembolism, warfarin is used. Atrial flutter differs from atrial fibrillation by ECG. On ECG, there are continuous and regular atrial activation with rate 300 beats per minute and ventricular rate 150 beats per minute as a sawtooth pattern, most obvious in leads second, third, and AVF. Treatment. Overdrive pacing and radiofrequency ablation are used for atrial flutter treatment besides of methods used for treatment of atrial fibrillation. On this picture you can see the example of atrial flutter. Atrioventricular tachycardia. On the ECG, in atrioventricular tachycardia, we can see tachycardia without normal QRS complex, with normal QRS complex is registered. Treatment of supraventricular or atrioventricular tachycardia. This tachycardia is converted to normal sinus rhythm by vagal reflex, adenosine, verapamil, cardioversion, cardiac pacing, and radiofrequency ablation. An example of supraventricular tachycardia you can see on this picture with regular rhythm and rate from 150 to 250 beats per minute. QRS complex is normal, not wide. Ventricular tachycardia, it is caused by re-entry wave in myocardium of ventricle observed at patient with a severe injury of the heart always leads to hemodynamic disturbances like a shock, circulatory arrest, often transforms into ventricular fibrillation. On the ECG, any wide QRS complex tachycardia should be considered ventricular tachycardia until proved otherwise. Treatment: hypotensive, ventricular, requires synchronized direct current cardioversion with more than 100 joules. Ventricular tachycardia with stable blood pressure can be treated with drugs such as lidocaine, procainamide, or amiodarone. On this picture, you can see an example of paroxysmal ventricular tachycardia with wide QRS complexes. Ventricular flutter, electrocardiographic waves with large amplitude with continuous, ongoing, and sinusoidal aspect. The components of the QRS complex cannot be individualized. Electrical activity is impossible to identify. A character that allows differentiation from a ventricular tachycardia in which is possible the distinguish between individual components of the QRS complex. Flutter wave frequency is about 180 to 250 beats per minute. Ventricular fibrillation is caused by chaotic re-entry waves in the myocardium of ventriculus. Clinical feature is suddenly syncope. On the ECG, chaotic irregular oscillations of isoline or with frequency more than 250 beats per minute, QRS complex and T waves do not establish. Treatment is with cardiopulmonary resuscitation, including defibrillation. Ventricular fibrillation represents the disappearance of organized ventricular electrical activity. It is the most serious cardiac arrhythmia due to serious hemodynamic consequences which are inducing loss of pump function of the heart, collapse of cardiac output, and of blood pressure. Most of the times, ventricular fibrillation is irreversible, fatal, and the measures of CPR and external electric shock are not quickly applied to obtain an efficiency heart rate from hemodynamical point of view. Bloks. Sinoatrial block is characterized by intermediate intermittence of heart rate. On the ECG, sinus pause is temporary cessation of sinus node activity seen on ECG as disappearance of P and QRS T waves. Atrioventricular block, first degree AV block. On the ECG, interval PQ or PR is more than 0.20 seconds. Clinical features are absent. Second degree AV block. Some normal P waves are followed by QRS complexes, but some are not. Three types exist. In Mobitz type 1 of the second degree AV block, the PR interval progressively lengthens with each beat until the atrial impulse is not conducted and the QRS complex is dropped, so-called Wenckebach phenomenon. In Mobitz type 2 of the second degree AV block, the PR interval remains constant. Beats are intermittently non-conducted and QRS complex dropped. These types of AV block clinically showed up by intermissions of in high-grade second-degree AV block, every second or more P wave is blocked and it results in ventricular bradycardia and hemodynamic disturbances. Third-degree AV block. Heart block is complete. There is no electrical communication between the atria and ventriculus and no relationship between P waves and QRS complexes that result in ventricular bradycardia and hemodynamic disturbances. On this picture, you can see an example of third-degree AV block. without connection between P and QRS complexes, but with connection between P's and between RR intervals. Left bundle branch block and right bundle branch block ACG signs. Right bundle branch block prolongation of intrinsic second and first and second more than 0.05 seconds in V1 and V2 leads. Complete right bundle branch block is showed up by wide QRS complex from first to third more than 0.11 seconds. Clinical features are absent. Here on this picture you can see an example of right bundle branch block with this specific type of V1 and V2 leads, like M-shape. On this picture you can see an example of right bundle branch block plus first degree of AV block with prolongation of PQ interval more than 0.20 seconds. Left bundle branch block prolongation of intrinsic first and second more than 0.05 seconds in V5 and V6 leads. Complete left bundle branch block is showed up by wide QRS complex more than 0.11 seconds or more than 0.12 seconds sometimes. Clinical features are also absent. On this picture you can see an example of left bundle branch block with a specific arrow in the first AV, L, V5 and V6 leads and deep S in the leads V1, 2, 3, sometimes even 4. Also an example of left bundle branch block. Treatment of blocks. Main disease should be treated in acute conditions. Sometimes atropine could be effective. If there are the hemodynamic disturbances, pacing is used. And types of artificial pacing is percussive pacing, transcutaneous pacing, transvenous pacing, and permanent pacing. Types of permanent pacemakers, it's single chamber and dual chamber pacemaker. Single chamber pacemaker, ACG example. Also single chamber pacemaker. Dual chamber pacemaker, ACG example. Types of pacemaker, it's fixed rate pacemakers said to work at a certain heart rate if the heart's own intrinsic rate dropped below a preset number, the pacemaker would begin to pace at a preset rate. Rate-responsive pacemakers determines what the heart rate should be from moment to moment. What are pacemakers prescribed? When are pacemakers prescribed? The indications for pacemakers can be bradycardia, fibrillation, heart failure, syncope. And thank you for your attention.